We have a cover story in CardioSource WorldNews that's taking a look at the whole concept of dual antiplatelet therapy. How much is enough? How much is too much? It's kind of a, if you'll pardon the expression, a three bears problem. Too much, too little, is it just right? You know, the guidelines say at least 6 to 12 months of dual antiplatelet therapy following DES unless there is a high risk of bleeding. Now that's the guidelines. Longer? Well, Trilogy ACS certainly would support that. 6 months is probably enough, however, if you look at Prodigy, for example. 24 months of dual antiplatelet therapy was no better than 6 months. And FAST-MI, the use of DAPT at 1 year, was not a predictor of 5-year mortality. So where are we in terms of just what do you recommend? Yeah, we know what the guidelines say, but you've got to look at the data at this point and look at it and go, what should we be doing? So towards that end, I'm with Dr. Roxana Mehran and from Mount Sinai. This has got to be confusing for anyone. The best people in the business are looking at this and going, what should we be doing at this point in time? Based on what I just said about the statistics, where are you with this whole issue?
Well, years ago, we would call this the $64,000 question. It's really the $64 billion question. I don't know that we know the answers, unfortunately. This is I think that there's a tremendous interest, and I'm hoping that given the important value of this, that people will begin to actually perform prospective randomized clinical trials that could answer the question, because this is a daily question. It's not about what should be the duration. It's about when can I stop DAPT safely. Correct. After I've put in a stent. Yeah. We have some data from the observational registry that I presented and published in the Lancet last year, and that was the Paris study, where we said that we saw this in the all-comers, no exclusions. We really got as granular as possible. What was the reason you stopped your therapy? Did you have surgery? Was it because you were bleeding? Were you not compliant? All of those very, very important modes of cessation of DAPT. And we found very interestingly that physicians, when they discontinue DAPT, it's totally fine. Maybe even if they decide 3 months, if they decide 6 months or 12 months. So the art of medicine is working, which is good news for us.
That's good news, that is.
And but interruptions and disruptions were on the wrong side of the equation, especially disruptions. Interruptions not so.
Now, interruption was defined as what?
When you stop within and restart in 14 days, voluntary, because you need a surgery or some reason to interrupt your therapy for less than 2 weeks.
And disruption?
Disruption was either non-compliance or bleeding or some kind of an event, or just stopping abruptly without any guidance from any physician that is a cardiologist. So those were really important to note that disruption, especially in the first 30 days, was extremely hazardous. Right. So no, you shouldn't just stop taking DAPT in the first month after DES or BMS. And this wasn't stent related, it was DES or BMS.
And is there any test currently at the present time that makes sense to give broadly to patients to see how they're responding to antiplatelet therapy? Those have seemed to be rather depressing in terms of outcomes in recent years.
I think that we don't have enough clinical evidence to actually guide our stopping or moving forward or not with the responsiveness to clopidogrel. I think that is the wrong way to unless we have really good evidence. I don't think we should be doing that. But what we do need, especially with this next generation DES, is perhaps a prospective large randomized study where 3 months versus 12 months is examined, because at the moment, as you know, there's going to be a huge, very late or long prolonged DAPT with up to 2 years, which...
Well, at this meeting, there's a poster downstairs that talks about very, very late, and it was, I think, 5 years. Yeah. They had found something like 8 patients who had 5 years after dual, and it was certainly stent thrombosis. We don't want to have patients treated for 5 full years, though, do we?
There's no way. Obligatory DAPT for prolonged periods of time should not be acceptable to us as a therapy for our patients who are in their 60s, because they have to live. They have, you can't be on dual antiplatelet therapy without interruption for a long period of time. And the good news from Paris is that under the guidance of the physician, it works to interrupt if you need to.
So what's your recommendation? What do you do? We know what the guidelines say. What do you do?
To be honest, I follow the guidelines, but in certain patients who are at high risk for bleeding, I don't ration the use of DES anymore, because I really do feel that these new data, especially with the observational data that we have, that after 3 months, the ischemic events are extremely low, even off DAPT. In fact, most of the events occurring on DAPT rather than off DAPT.
Right.
So what's more important is to really look at the patient's risk profile. We have to be doctors after all, and when we do practice medicine, we actually do a really good job, and we showed that in Paris. So that's what I try to do, is to basically take a look at every patient, look at their ischemic risk, their bleeding risk. 3 months is a must, I believe, after DES for now, and evaluate them. If they're having issues with even minor but clinically important bleeding, like nosebleeds or bleeding that's really terrible for them and hurting their daily life, and I feel that the ischemic risk is small, I will stop, and I won't feel bad about it. But if they're doing really well and they're tolerating the dual antiplatelet therapy, I don't think there's anything wrong with continuing it. This is not in the ACS population, where I do believe 12 months is obligatory.
Okay, absolutely. And thank you very much, because this is an issue that is not going to be resolved anytime soon. So whenever you can get an expert to weigh in on it, I really appreciate it.
Well, I appreciate you covering these incredible stories, and congratulations to you as the editor, but to all who contribute to the journal.
Thank you. And please go to the CardioSource World News, because we do have a cover story on this very topic. For CardioSource World News, I'm Executive Editor Rick McGuire.